Welcome to the Pain Pod. This is the podcast where you can hear from your favorite physicians on their experience treating pain and how they got there. On this week's episode, we are joined by interventional pain physician Dr. Michael Orzo. Dr. Orzo received his education and training at The Ohio State University, where he attended the College of Pharmacy and the College of Medicine, where he completed his fellowship and residency with the Department of Anesthesiology, where he later served as the medical director of the Ohio State Pain Control Center. Dr. Orzo brings a holistic approach to his practice with over 20 years of experience. He is a registered pharmacist and board-certified anesthesiologist with subspecialty board certification in interventional pain management with the American Board of Anesthesiology. Thank you for joining the Pain Pod today, Dr. Orzo.
My pleasure. I'm happy to be here.
We are incredibly excited to learn more about your extensive experience treating pain and the minimally invasive therapies and techniques you use to treat patients. Could you share a little about yourself and what brought you into pain management?
Sure. In undergraduate, my undergraduate education, I was looking for a medically related field, and I went into pharmacy. And when I was in the College of Pharmacy, I had some experience with hospital pharmacy, which made me interested in medicine. I then went to medical school and was drawn into anesthesiology because it's essentially applied pharmacology. And while I was doing my anesthesia rotations, I did a rotation in pain management, and I was really drawn into that because of the long-term patient interaction. With normal anesthesia, you have a very short patient interaction, and oftentimes patients don't even know or remember who you are. But in pain management, a lot of times the relationships that are formed go for years. In fact, I've been treating some patients for over 20 years, and I get to know them pretty well.
That's awesome. It sounds like long-term patient interaction is something that's really important to you. Speaking of patient interaction, what do you find in your practice to be an effective option in combating pain while keeping patients active, especially if you've seen some for extended periods of time over many years?
As interventional pain physicians, we have quite a bit of tools available to us. One thing that I find particularly effective for patients is spinal facet joint radiofrequency ablation.
And what do you like about that type of modality and treatment?
A lot of patients aren't familiar with these as a treatment option. For spinal arthritis, there are very limited treatment options, and in most cases, physicians will try to prescribe anti-inflammatory drugs, sometimes steroids, and sometimes opioid medications, all of which aren't very effective. Conservative therapy like chiropractic care and physical therapy are also not really effective over the long term. Spinal arthritis is a very common condition and affects people of all ages. In my experience, I've seen patients as young as 18 and as old as 89 who I've treated for spinal arthritis. So it's not limited to any specific age, gender, or even activity level. Most patients with spinal arthritis will experience quite a bit of pain and stiffness, either in the low back or the neck, that can be brought on really by nothing. In most patients, spinal arthritis manifests as a constant ache, which will become more of a throbbing sensation when it becomes more severe, and even an occasional stabbing sensation. In a lot of cases, it'll mimic nerve root pain, especially in the lower extremities. And the arthritic referral pattern is often to the anterior thighs to about the level of the knee, sometimes even all the way to the ankle. And so it can be mistaken for other conditions. And in many cases, patients will have significant interventions like surgery that are ineffective because they're aimed at treating the wrong condition.
When would you say a good time for a patient to come see you would be then to kind of maybe help check other routes for them, other options for treatment? Because you did just mention they will sometimes end up getting surgeries that don't address the problem. So what would you say would be some good indicators that they should come see you prior to considering a surgery, especially when it would be suitable to get ablations?
Well, I would say that patients who have chronic, long-standing neck or back pain of an achy type nature that can or may not be referring into the upper extremity or lower extremity, if conservative measures, as mentioned, like anti-inflammatories, physical therapy, and possibly even chiropractic care, either are ineffective or stop being effective, that would be the time to see me prior to evaluation for surgical options because, like I say, a lot of times the arthritic type pain is mistaken for another condition that doesn't require and will not improve with surgery, although patients do end up having surgeries, oftentimes even fusions, uh, hardware fusions that will not help this condition.
Awesome. That's really insightful. Could you share some good success stories of any patients off the top of your head that you've treated with this, that you've seen improvements? What's that been like for them? What's that been like for you?
Oh, absolutely. Over the years, I've seen, like I say, I've seen patients as young as 18 and as old as they're in their 80s. Um, Younger patients tend to be athletes who have had some type of multiple trauma to their back, football players, gymnasts, horseback riders, who over the course of time will have multiple what's called repetitive compression injuries to the spine. Um, the spine's kind of like an accordion. If you think of it, if you bounce up and down frequently, that can lead to more rapid progression of arthritic change. So, depending on the age of onset, oftentimes it can manifest at different ages throughout an individual's life. Um, by the age of 30, about 30% of people would have clinically significant arthritic change in either the low back or the cervical spine if they were to obtain an MRI. But most 30-year-olds aren't symptomatic with spinal arthritic pain. Once an individual has some type of even minor trauma, oftentimes the pain from the arthritic changes will become symptomatic. And at that point, that's when treatment should be undertaken. Obviously, if someone has asymptomatic spinal arthritis, it should just be left alone and not treated in any way.
Hmm.
Normally, when a patient presents to our clinic or if I see them, I will assess them for the presence of spinal arthritis both by history and physical examination, as well as obtaining a diagnostic study, usually an X-ray to start. If those indicators seem to demonstrate the presence of arthritis and or arthritis type pain, normally what we'll do is what's called a diagnostic medial branch nerve block, where under X-ray we block very selectively just the nerves that innervate the arthritic joints. The purpose of that block is to determine whether or not the arthritic changes are the primary source of the pain. In patients who seem to be appropriate for that diagnostic block, the vast majority of them do extremely well and receive about 80 to 90% or more benefit while the block is effective. The diagnostic block is only expected to last for a short time, but from an information standpoint, it gives us important diagnostic information as to the source of the pain.
How long do those normally last for? Is it dependent on patient when you're doing these diagnostic blocks? What's the expected end result and time frame of that?
Well, the diagnostic blocks are done with local anesthetic, and they're meant to only last anywhere from 4 to 6 hours to a day or so. With that block, the duration of action isn't important, or what's most important is the degree of benefit or improvement that's seen while the block is effective. And what I mean by that is if the block provides even 4 to 6 hours of significant pain relief, 70, 80, 90% or more, that indicates that the joints are the source of the pain and that proceeding with what's called a radiofrequency ablation would likely give them long-term relief. I would point out too that the treatment for these conditions that I'm describing, the diagnostic blocks as well as radiofrequency ablation, which I'll discuss here in just a minute, are all done through needle sticks. They are very quick procedures. The diagnostic blocks take anywhere from 3 to 5 minutes, if that, and radiofrequency procedures can take anywhere from about 15 to 20 minutes, but it's a very short procedure for long-lasting relief.
Awesome. So let's get more into the procedure itself. When you're doing the radio frequency ablation, what do patients usually expect? What do they walk into? How long can they expect that relief to last them? Obviously, it's dependent on patient, but in your experience, what would you say the average would be?
Well, assuming that we do the diagnostic blocks and receive a positive response, which, as I mentioned, would be 80% or more benefit for the duration of action of the local anesthetic block, then we would likely proceed with the radiofrequency ablation. During that procedure, it's actually very, very similar to the procedure that we do for the short-term block, but instead of applying or injecting local anesthetic on the nerves that innervate the facet joints, we actually place a special needle called a radiofrequency probe and cannula up against the nerve and apply radiofrequency energy. When we do that, it actually scrambles the nerve and prevents it from carrying pain signals, usually for a median time period of about 12 months. The vast majority of patients who receive radiofrequency ablation treatments fall between a 9 and 15-month duration of benefit after the ablation. If you look at a curve where the majority of people fall, it would be closest to about 12 months. After that 12-month period, the nerves do regenerate and the pain can start to return. But if that happens, we can just repeat the ablation and get a similar response.
How many times would you say it would be appropriate, or you've seen ablations done? You did say they regenerate, the nerves regenerate, so it can be repeated. Do you have patients who have gotten them over many years, or do you see people who come back maybe once every 3 to 4 years? In your experience, what do you normally see?
Well, like you said, it's very patient dependent. I would say the average patient gets about 12 months of benefit. But I recently saw a patient back in the clinic for a repeat ablation who was about 3.5 years out from their last ablation. I guess the key takeaway point here, though, is that there's no cumulative adverse effect from having repeat ablations. And it's a very minimally invasive procedure that's done through very specialized needle sticks. And like I say, it's not extensive type procedure. It's very quick and takes about 15 minutes to perform. For the degree of benefit and the improvement in pain, activity level, and quality of life, patients tell me it's very, very worth it. Over the years, I've seen people who I would say that want to perform activities. Especially, I've seen golfers. I've treated professional golfers. I've treated professional athletes who have essentially been almost immobilized. The nice thing with the radiofrequency ablations as well is that they don't really require any recovery time, whereas a major back surgery can take 6 weeks to 6 months of recovery time. There's no restrictions and no recovery time from the radiofrequency ablation. The most common side effect is a very short-term muscle tight pain just from the needle sticks themselves, but that's about it.
Do you recommend anything in conjunction to that therapy as well? Say physical therapy, can people return to chiropractic care if that's a route they're looking for?
Yeah, absolutely. In fact, a lot of people are limited in terms of rehabilitating their back or their neck because of pain. Oftentimes, when we complete the radiofrequency ablation, if the facet joints are the primary source of the pain, I essentially explain to them that we buy them a window of opportunity to rehabilitate their spine. Their range of motion improves, their ability to strengthen supporting structures improves, and in a lot of cases, even when the nerves regenerate, the pain isn't as severe because they're able to get the muscles working and they're able to strengthen other supporting structures. And in doing so, it can actually take some of the stress forces off of the spine itself, and it becomes a protective mechanism. So they're less likely to injure themselves.
Awesome. That's really great. Do you have anything else you'd like to share with us?
Yeah, I've been talking a lot about spinal facet joints. I should kind of mention what a spinal facet joint is. There are what are called synovial joints in the spinal region, and they are in the posterior portion of the spine. The discs are in the anterior, the front portion of the spine, and the spinal canal is present, and then the joints are kind of in the back of the spine. So oftentimes, another type of symptom that patients will have is they'll have pain with extension of or looking back with the neck or bending backwards at the waist, and the pain will be relieved with either flexing the neck slightly forward or flexing slightly forward at the waist. In a lot of cases, when patients present to see me, one of the first things I'll notice is that they're slightly flexed forward at the waist, and that actually takes the pressure off of the spinal facet joints. You can imagine that the joints in the spine are kind of like the joints in your finger. And in a lot of cases, patients who have arthritis in their hands will have obvious deformities. They'll have swelling in those joints and significant stiffness in those joints. It's a little bit different in the spine because you can't see the joints. And so even if you don't have the manifestations in the hands like you would have with osteoarthritic change, the similar symptoms are present in the spine, but you can't see the joints. So it's less obvious that the arthritis is there in a lot of cases. That's why it's important to come in and to be evaluated, because by history and physical examination, it's a condition that can be picked up relatively easily by someone who has experience in treating it. And like I said, the treatment option that I've kind of outlined today is about the most effective treatment option available for long-term relief.
Dr. Orzo, do you have any final thoughts you would like to share with the listeners, people tuning in, kind of recap what you've just gone over with us?
Definitely. Based on what I've said, I would strongly encourage anyone who has persistent or chronic neck or low back aching, stiffness, or pain to consider undergoing an evaluation. If the arthritis is present, then definitely the treatment option that I've discussed is very likely one of their best options. And as I mentioned, it's a very minimally invasive and very effective treatment option for spinal arthritis. And I think that a lot of patients are needlessly walking around with severe spinal pain that can be easily treated.
Well, I really appreciate your time, Dr. Orzo, and all the information you've shared with us. Listeners, if you want to schedule an appointment or just learn more, you can go to our website at ipscolumbus.com. Thank you for your time, Dr. Orzo.
My pleasure.